Very, very special visitor today, and I have to say this is because the fellows gave us feedback that we have not had enough lectures on palliative care in nephrology as well as on difficult bioethical issues in nephrology. And this is something that does come up on the nephrology boards, and so we wanted to remediate this deficiency and invite the national expert on both bioethics and palliative care in nephrology. I have to say, when I researched this topic, I had actually already known about Dr. Moss through our collaboration, but when I went to PubMed to research these two topics, his name and his many impactful publications kept coming up. And then kind of reading a little bit more about his lifelong dedication to these two topics, I discovered that he actually has led many organizations specifically focused on improving end-of-life care in nephrology and also ethical issues in nephrology. So just to name a few, he founded, along with another individual, the Coalition for Supportive Care for Kidney Patients, which he currently chairs. He founded the West Virginia Network of Ethics Committees, which he directed for 30 years, and the West Virginia Center for End-of-Life Care, which he directed for 14 years. He founded and was chair of West Virginia University Hospital Ethics Committee for 32 years. He's done a number of things in American Society of Nephrology, Renal Physicians Association, and other organizations, and received a Distinguished Service Award from Renal Physicians Association and a Medal of Excellence Award from the American Association for Kidney Patients. So definitely an expert, as I said, and someone who's had tremendous impact in both of these areas. He also generously gave of his time yesterday and spent about an hour with our fellows on a dedicated workshop on how to manage difficult ethical issues in nephrology. So Dr. Moss, thank you very much for coming to visit us. We're delighted.
Thank you for that very kind introduction. One has to be careful what one allows to go on the internet, I guess, right? She dug down a little deeper than my brief bio sketch that I sent. All right. Well, let's start by unpacking this. So you've already heard about the Coalition for Supportive Care of Kidney Patients. About 20 years ago, we recognized that there were significant unmet palliative care needs for patients with kidney disease, and that treatment of patients with kidney disease needed to be more patient-centered. So we started the coalition for that purpose, and then this is Expand is a patient-centered outcomes research institute grant that I am a co-principal investigator on, and we recognize that we need to improve shared decision-making for older patients with advanced kidney disease. And we currently now, as part of this project, not only have a patient advisory group, but we have had 4 patient focus groups. So you're going to hear, as I describe things, what our patients have asked us to, what to call things and how to approach them. So my learning objectives are to define primary palliative care skills for nephrology clinicians, hopefully to meet some of those unmet needs. One of the issues that I was talking about with several of the nephrology faculty is estimating prognosis, and there are several validated tools to use to estimate prognosis for patients with kidney disease, and those will be necessary for 2 of the patients I'm presenting. Talk about evidence-based algorithms for treating pain and other symptoms, just so that you're all aware that these are available and you don't need to reinvent the wheel. Discuss shared decision-making as the model for making decisions with older patients about whether or not to start dialysis or continue dialysis, and then really, if time allows, we can look at some of these other resources. Oh, I'm not used to this. This is great. All right, so I'm going to present 3 cases to you: Mr. D, Mrs. Z, and Mr. R. Okay, and hopefully you'll indulge me, and I'll ask you some questions to get involved a little bit. All right, so, but before I go any further, just this year, the International Society of Nephrology published a paper in Kidney International about kidney supportive care, and management of patients that they say, what did they call it? They called it conservative kidney management. Our patients don't like the term conservative kidney management. They feel like conservative means they're not getting good care, that something's being withheld. So in this talk and in the literature, more and more, hopefully, you're going to see the term active medical care without dialysis. It's active care, it's just towards a different goal, okay? And then the other thing is, they explicitly said that kidney supportive care is a component of the care of patients with kidney disease that should be integrated into the care of patients with kidney disease. So kidney supportive care is not a poor first cousin at this point. It's now a key component of good care, okay? So I think that's important. Now, in terms of terms, let me walk you through this. So you've heard me use the term supportive care. You've heard me use the term palliative care. Our patients prefer the term, and our oncologist colleagues prefer the term supportive care as opposed to palliative care. In fact, I was telling Dr. Isakova that, or maybe somebody this morning, MD Anderson was the first one to change the name of their palliative care service to a supportive care service. And because I read that patients also preferred supportive care to palliative care, we went with that change too. And then the whole kidney supportive care community, including our coalition, went with the name kidney supportive care. So really, let's see, I think I went a slide. So primary palliative care, what we're calling kidney supportive care, primary palliative care, I'm going to define for you in another slide, but it's going to include active medical management, palliative dialysis, a time-limited trial of dialysis, and waiting to decide. Active medical care is the one I'm going to talk about most, but there are these other options too, so that patients don't need to lock themselves into what we would call maintenance hemodialysis or maintenance peritoneal dialysis if they want to first see if it's something they want to do or not. So kidney supportive care is primary palliative care, but then in our, at least, literature, the nephrology literature, when we start talking palliative care, we're talking about a specialist team. And we have Dr. Wood and Dr. Hauser here. And Julie, are you here too? I'm sorry, Vermillion? Is it? Okay, all right. But so, and I'm going to talk about when you might want to refer to specialists in your care of patients with kidney disease. And then hospice is later down the line, it's part of the continuum of palliative care, but it's for people who are thought to be terminally ill. And unfortunately, because of Medicare guidelines, it's difficult to get concurrent hospice and dialysis. Technically, if the patient is dying from a non-renal cause, such as cancer, you should be able to get concurrent hospice and dialysis. But in many portions of this country, hospices will not accept dialysis patients until they've stopped dialysis. Okay, so we've gone through that. So now, what are primary palliative care skills? Those are ones that we would hope nephrologists and nephrology APPs would be comfortable with doing. Management of uncomplicated pain and symptoms, using validated tools like the Edmonton Symptom Assessment Scale Renal, or the Integrated Palliative Outcome Score, or the Dialysis Symptom Index, and using some of these algorithms, and I'll refer to them a little bit more later. Shared decision making that includes the overall condition of the patient and the prognosis, the patient's values, preferences, and goals, and identifying what's most important to the patient or what matters most to the patient. And it could include treatment limitations, such as whether or not they want to be intubated, whether or not they would want pressors, whether or not they would want to go to the ICU. And it could even include completion of something called a PULSE form. I think it's called PULSE in Illinois too, right? Used to be called physician orders for life-sustaining treatment, but now APPs can sign them too, so I think it's pretty much called portable orders for life-sustaining treatment. So it could include that advanced care planning and then really coordinated end-of-life care. Okay, so that's primary palliative care, and that may seem like a lot. So I want to draw this distinction for you. Back in 2013, Tim Quill and Amy Abernathy drew this distinction that generalist or primary palliative care, which is what I've just described that nephrologists might provide, and then specialist palliative care. And interestingly enough, the International Society of Nephrology, in this article in Kidney International, accepted the Quill-Abernathy classification and sort of the delegation of responsibilities. So that this table or this box from this Kidney International article basically accepts the recommendations in the earlier Quill Abernathy article from the New England Journal of Medicine. So this is just sort of to lay out to you the landscape. And now let's get to our first patient, okay? Mr. D is an older patient who's failing to thrive on dialysis. He's weaker, and he's now unable to safely transfer into the dialysis chair. So here we have Mr. D. He's 77. He's been on dialysis for 5 years from amyloidosis. He's frail. He has protein-calorie malnutrition. His BMI is 16. His albumin's 2.3. As a result of a recent hospitalization, he's declining in functional capacity. He's now wheelchair dependent. He's had a previous stroke. He has heart failure with a reduced ejection fraction. He's oxygen dependent. He also has non-malignant bilateral pleural effusions, and he has to have recurrent outpatient thoracentesis. He's been hospitalized. I said he became deconditioned, and it was during that hospitalization that it was now realized he's not going to be able to independently transfer to a dialysis chair, and that is significant, and I'll show you why in just a minute. The dialysis center, unfortunately, where he dialyzes, does not have a Hoyer lift, and they would not be able to safely get him into a dialysis chair, which creates a problem, obviously, for those of us who make rounds in outpatient dialysis units or have made rounds and realize the difficulties in getting patients in and out of dialysis chairs. And the patient wanted to stop dialysis and enroll in hospice, but his wife disagreed. So let me see if I can get agreement. Dr. Wood, would a palliative care consultation be appropriate at this point? Yeah. Okay. All right. That was easy. All right. So, Dr. Tima, what would you say his prognosis is? Poor. Okay. I agree. Could you unpack that for me a little? Yeah. Yeah. All right. So I'm having fun with the names of the physicians I've learned in the room. Dr. Hauser. Dr. Hauser. Dr. Moss. The patient wants to stop dialysis, but his wife disagrees. So how would you, wearing your palliative care hat, what might be your strategy for approaching that conversation?
Well, I talked to my friend Dr. Wood, Dr. Vermillion, or anybody else. No, I think that these disagreements aren't uncommon or are common. And I think I'd want to have both people in a room and talk together.
Good.
And try to understand where he's coming from and where she's coming from. It sounds kind of simple.
Yes.
In this auditorium, but that's sort of where my head would be. And
Sure.
try to normalize that and say that this is not uncommon. And think with them about what his priorities are and what her needs are as well.
Okay, good. All right, good. So a couple of questions that came to mind that we've already addressed. What's his prognosis? How should discussion with Mr. D and his wife be approached? And what are the options at this point for his treatment? Who's willing to help me? What are the options? We could
Stop dialysis.
We could stop dialysis. We could
Get a Hoyer lift and continue that.
get a Hoyer lift and continue dialysis. We could, my third that I like, that I discussed with Sam. Are you here? Huh? What do you want to do? Hospice, actually, that would, yes. Okay, he wanted to do hospice, right? That would be part of our stop dialysis approach, right? So a time-limited trial, right, of seeing how he does, finding a Hoyer lift or a dialysis center that could accommodate him, and really impressing on the wife the challenges that we're seeing and seeing how he does. But he would have to agree to that, right? He would have to agree to that. Okay, so a number of years ago, we have an evidence-based practice center do a systematic review of the medical literature that led to the development of a clinical practice guideline basically on who should be dialyzed. It's called Shared Decision-Making in the Appropriate Initiation of and Withdrawal from Dialysis. And I emailed a PDF of this guideline to Marissa, and Marissa, I think, is going to put it on your shared drive. And so it's accessible to anybody who would like to read it. But what they found in literature review, and then 10 years later we repeated the literature review, and if you will, for those researchers, these are statistically significant independent predictors of poor prognosis. If you do what's called multivariate logistic regression analysis, these things are still standing, if you will, after you've done your stepwise regression and the others have fallen out. Okay, so age. Now, we're not discriminating, but the older you are, let's see, I'm going to do this. The older you are, the more likely you are to die. Would you agree with that or not? Okay, 80% of the people in this country who die are over the age of 65, and we all know the older the person is, the more likely they have comorbidities, okay? And so it's not age discrimination, it actually was just the fact that age was a predictor. Comorbidities was actually even a more important predictor than age, but also functional status, nutritional status, and frailty are important predictors, as is cognitive status, especially dementia, okay? And if you look, Mr. D has what? He has 5 of the 6 predictors of a poor prognosis. So Dr. Chima was very astute in saying that his prognosis was poor. All right, but we can take this a step further. We can plug it into a validated prognostic calculator. And so this was a study that was done in which there was external validation of this sample, and we plugged his albumin, the fact that the nephrologist would not be surprised if he died in the next year. He did not have dementia, did not have peripheral vascular disease, but as Dr. Chima noted, even with continuation of dialysis, he only has a 50-50 chance of being alive in a year. Okay, so we have a validated way of saying his prognosis is poor, and in our discussion with the wife, it would be important to say that his prognosis is poor even if we continue dialysis. But it's always nice if we have a second validated prognostic marker, right? And so the French Renal Epidemiology Information Network has done a huge study, I think of 14,000 patients or something, where they did both, again, a derivation sample and a validation sample, and they developed adjusted odds ratios for 6-month mortality in dialysis patients, and then they assigned points to each of the risk factors. And notice that with his body mass index of less than 18.5, Mr. D gets 2 points. With his heart failure, he gets a point. With his, let's see, I'm having trouble reading this, but notice he gets the points. And then notice being totally dependent for transfers gives more points than any of the others. And in this particular study, being dependent for transfers was the worst prognostic factor. And when we add up his points, it turns out he had 8 points, and he fell into the category where he had essentially a 50-50 chance of being dead in 6 months. So this is interesting in that these two validated prognostic tools confirmed each other, which is reassuring, right? So that we can say, as Dr. Chima said, his prognosis is poor. Because if you think about it, if somebody tells you that a patient with cancer has a 50% 6-month survival, wow, you think that's horrible, right? I mean, that's even worse than pancreatic cancer, right? Okay, so he has a really bad prognosis. And then I'm holding up this book, and this is free online, and you can download it. But it tells you how to approach cases like this. And so the way it advocates is a process called shared decision-making, and it's a process of communication. I think I was talking to the palliative care team about teaching communication skills, right? Teaching communication skills to the nephrology fellows. And so it's a process of communication. Notice this was defined by Michael Barry and his colleagues as the pinnacle or the very height of patient-centered care is to do shared decision-making. And it's a process of communication between the patient and the physician, could include the patient's wife or other family member, in which they first learn the patient's values. What's most important to you, right? Or what are your values? What are your preferences? What are your goals? And then the physician presents the diagnosis, the prognosis, the treatment options, and then the benefits and risks of the treatment options. Okay? Make sense? And then together, hopefully, they better understand the relevant factors, and then they could share responsibility for the decision. So Dr. Hauser, would you agree that in sitting down to talk to the patient and the wife, this is what we should be doing?
I would. I have a little bit of a quibble with the order of things.
Okay.
At least on your list, which may not be.
Sure.
In
Tell-
other words, a lot of, we were talking about this earlier, there's a lot of upfront presentation of some medical stuff in order to give the context for this shared process.
Right, right. So you have to provide some information in order to then be able to have the discussion. Okay, fine. All right.
Yes.
So you would like me to switch my reaching agreement. You want me to switch the physician presents before the patient value? Okay, all right. Thank you. All right. Okay, so researchers have operationalized this process of shared decision making, and they've said there are 9 elements that they've identified if the process is done well. First of all, when you interview a lot of dialysis patients, they say they weren't even aware they had a choice. They didn't know that they could do something other than dialysis. So first of all, the patient's aware of the choice and that there is a decision to be made, and actually that they could participate in the decision. Oh, because again, when you look at studies of patients on dialysis, 50% or more of the time they said the nephrologist made the decision. They actually didn't feel like they were a participant in the decision. So that there's a decision to be made, then they get to express their needs, their values, their preferences. They're informed of their prognosis and all options. Okay, that would be if they want to know all their options, informed of all their options, the benefits and risks of each. And notice the role of patient decision aids. One of the things that have been highly recommended when you're doing shared decision making is that you have a patient decision aid, because that standardizes the information that the patient's being given, and hopefully it's been studied in such a way that it's not biased and that it's understandable to patients. So I told you before I'm involved in this project. So one of the things that we heard from our patients is that they wanted the patient decision aid, if we developed one, to be at a 5th or 6th grade reading level because of health literacy considerations. And they also wanted the people shown in the decision aid to reflect the population of patients who might be on dialysis. So they did not want only white patients. They wanted persons of color, of different nationalities or different races to be shown to reflect, so it might have meaning for them. The reason why I'm bringing this up is I'm going to be showing you a video that we created as part of this effort to improve shared decision making for older patients with chronic kidney disease with eGFRs of less than 20 milliliters per minute, so that this would be available to show to patients as part of this process. Okay, they didn't want the decision to be rushed, right? They wanted to have time to think about it. They wanted to be a co-equal in the decision, and they wanted to be a co-equal in the plan of care that was developed as a result of this decision, okay? So how well do you think we're doing with shared decision-making in our patients with chronic kidney disease based on studies in the literature? Were you a deputy editor for AJKD? Is that right?
Associated editor.
Okay, all right. So there was a study in AJKD that came out in 2022, and the researchers, the primary author was at Tufts. Kieran Layden and Daniel Weiner was, I think, the senior author, but it actually was 352 CKD patients from 4 different sites around the country, and this shared decision-making 9 questionnaire, SDM-Q9, 100 if you're doing optimal shared decision-making, 0 if you're doing very poor shared decision-making. Anybody want to guess what the mean score was in this study of 352 patients? See, who have I not picked on yet? So let's see. Dr. Leidner. 50. Oh! Fortunately, it wasn't quite that bad. But you're onto something. It was 52 out of 100. If all of us are high achievers, right, we wouldn't be where we are. Would we be satisfied with a score of 52 on an exam? No. Okay. So the words they used in their article were suboptimal. Shared decision making is suboptimal. Okay. So one of our goals with this project is to improve shared decision making. So I know my colleagues from palliative medicine like Vital Talk or Nephro Talk. But we have found in our experience that actually the ask, tell, ask approach can be easier for learners to assimilate into their practice with questions like, what's your understanding of your medical condition now? How serious is it? What's most important to you in receiving treatment? Are the things you wish to avoid? Who would you want to speak for you if you became too sick to speak for yourself? Those are questions. The tell is, if they don't quite understand the seriousness of their condition or just all of the different details, you fill in the gaps with the tell. And then the ask essentially uses the teach-back method. To be sure I've been clear, could you tell me in your own words what I have, what I've said? Or your wife wanted to be present but was unable to be. Can you tell me what you're going to tell your wife? And always we would ask, what questions do you have? And people have made the argument that what questions do you have is a question that really invites the patient to ask questions, as opposed to asking, do you have any questions, which says, well, the doctor's busy, I'm intimidated by the doctor, I don't want to take any more of the doctor's time, and I don't really think they want me to ask questions, so I'm not going to ask any. So at any rate, we have that, and then we've actually put it into a laminated card so that clinicians could put it in their pocket and could just refer to it, and then Medicare allows you to bill. If you're seeing a patient in clinic or in the dialysis unit or wherever in the hospital, you could add 99497 if you spent 16 minutes or so having this type of goals of care, advanced care planning discussion. And if it went 31 minutes as part of at least a 45-minute discussion, you could add the 99498. So that was case one, okay? Clearly needed a good discussion. The wife, what do you think happened? What's that? How did you know? But he didn't do well. What made you think that? You've been around the block once or twice, is that what you're saying? Okay, all right, so case two. Case two we're going to be able to do. More confidence, okay. So Mrs. Z is a 70-year-old hemodialysis patient. She's been on dialysis 2 years. She has hypertension, poorly controlled diabetes with retinopathy, neuropathy, nephropathy, peripheral arterial disease, an unsteady gait, and chronic right foot osteo. She's married. She has good support at home. She retired from the post office. She has chronic severe bilateral aching in her calves and numbness and burning in her feet and ankles. She can't sleep at night because of the pain. She occasionally cries on dialysis because the pain is so bad. And she has no history of substance use disorder. She's on gabapentin at a maximal dose. Most literature says 300 milligrams is the maximum dose of gabapentin for a patient on dialysis. You can sometimes push it to 600 milligrams if the patient can tolerate it, but her pain is still severe. Okay, so who wants to help me with this patient? I think I should go to a palliative medicine physician with this one, right? Dr. Wood is smiling. Dr. Wood, you want to help me? What? First of all, let's hear. Let me help you. What type of pain does she have? Neuropathic. She has numbness and tingling. But what about that aching in her calves? She has peripheral arterial disease. Yeah? So she could maybe have a little nociceptive pain too with some ischemia, although it's probably predominantly neuropathic. I would agree. Okay. What are her treatment options? She's maxed out on gabapentin.
You could add different neuropathic agent like an SNRI, a vaccine,
Okay. All right. Good. Okay. Well, in getting ready to present this case, I found a couple of articles in the literature that said adding nortriptyline to gabapentin actually got you better control of neuropathic pain than either one alone. So obviously there are contraindications and things you need to look at, but if you could start low, go slow with the nortriptyline, maybe start 10 milligrams at bedtime, right, just a tiny little bit. If she's tolerating it fine with no adverse reactions, you could titrate it. In my experience, often 25 or 50 milligrams in addition to the gabapentin may give you a little better control of the pain. But then the other thing that you said, I completely agree with, often, and in fact there was an article in the New England Journal of Medicine like 10 or 20 years ago that talked about the fact that with neuropathic pain, severe neuropathic pain, at least about half the time you need to use an opioid in addition to a typical drug for neuropathic pain to get good control of symptoms. I had a patient who couldn't sleep at night because of her pain, and so I gave her methadone at bedtime, and that worked. But and methadone, by the way, as you'll see on the next slide, is one of the drugs that's safer to use in patients with kidney failure, as opposed to morphine that you wouldn't want to use because the morphine metabolites can accumulate in renal failure and cross the blood-brain barrier and cause mental status changes and opioid neurotoxicity. So would she benefit from seeing a specialist palliative care? Well, actually, she did. She just saw Dr. Wood. All right? She did. Okay. And we'd already talked about what treatments we might suggest. And then this is just so that you're aware, this is what nociceptive pain is on the left. And notice for us as clinicians, the words they use are very important. Is it sharp, dull, aching, throbbing, which is more musculoskeletal type pain, or is it really, which is with the intact nociceptors or pain receptors? Whereas for neuropathic pain, there's disordered peripheral or central nerves, and the pain may exceed what you can see, and it can be burning, tingling, numb, shooting, stabbing, electrical zingers. Patients will often use terms like that. And patients can have both, in which case we would call it a mixed pain disorder, which makes me think of a mixed acid-base disorder, right? Right? We're all familiar with mixed, right, as it works out. All right, so what can you use? What's best to use in people with advanced chronic kidney disease? Acetaminophen, but that's really only for mild pain. My colleague Sarah Davison, who's a Canadian nephrologist, really likes hydromorphone as a medicine for pain. But hydromorphone is glucuronidated in the liver to hydromorphone 3 glucuronide. And I've seen opioid neurotoxicity in patients with CKD and on dialysis with hydromorphone. So I'm not as fond of it as she is, but she made the table, so she got to call the shots. Fentanyl is safe. Okay, fentanyl at least is safe from a kidney-related standpoint. I know we all know that fentanyl may not be safe as it's currently out in society right now. Methadone is safe. Gabapentin, typically we say up to 300 milligrams max, but, there are anecdotal reports of people tolerating 600 milligrams and it helping more than 300. If you stay with a gabapentinoid, Gabalin, Lyrica, doses up to 100 milligrams are generally considered safe. And then there are these other drugs that we sometimes use, tramadol, oxycodone. I actually happened to do a study with oxycodone. It worked fine. There were no adverse effects. And then we talked about dicipramine and nortriptyline. You want to obviously be watching for adverse effects, but they can also be used potentially effectively. But the drugs not to use are those in the right-hand column because, of the metabolites. And so only the older people in the audience probably even know what meperidine is. It was Demerol. Normeperidine was a metabolite, or norpropoxyphene was a metabolite, and they accumulated in renal failure and can cause opioid neurotoxicity. And then just to recall that when we're talking to Mrs. Z, we need to be aware that in addition to physical pain, there can be psychosocial pain, and so we would need, as part of our complete assessment, to be looking for those types of issues. And then I promised you, so this slide, and Marissa has the slides, and she can put them on the shared drive too, but there are really good tools for symptom assessment, and at least 3 sets of pain and symptom assessment and treatment algorithms. The British Columbia Renal Symptom Assessment and Management, University of Alberta website, and the New South Wales in Australia has a website as well, so that you don't have to think, I have to figure out what to do on my own. This reviews the evidence and lets you feel more confident treating your patient's symptoms. All right, so we can move on to Mr. R, who we're going to spend a little more time on. So he is 90, nonagenarian, and they're not sure about starting dialysis or not. So Dr. Chima, since you were so nice, I'm going to present Mr. R and then ask you what you think, okay? Is fair enough? She's really been very agreeable. She's been one of the stars of my visit, just so that you know. Really, it's really been good. All right, so this is a frail 93-year-old who would need help to transfer into a dialysis chair from his wheelchair. But he's not totally dependent for transfers, okay? He has stage 5 CKD from polycystic kidney disease. His eGFR is 6, but he's actually not overtly uremic yet. He has type 2 diabetes and coronary artery disease. He lives with his son, who he really relies on as the decision maker. Years ago, I mean, he's 93. They could have decided years ago he wasn't going to do dialysis if his kidneys failed, and that was their previous decision. But he was recently hospitalized with AKI on CKD. Fortunately, it didn't get so bad that he needed dialysis, but that shook them both up, and now they're not sure maybe they do want to do dialysis. So his kidney function is now down to an eGFR of 6. The nephrologist had frank discussions. I talked to the nephrologist. He really thought he had talked them out of dialysis, but he hadn't. And so the nephrologist had this great idea. I'm going to send this patient to the vascular access surgeon, and I'm going to let the vascular access surgeon talk about the types of surgery that might be needed with the hope that, oh, he's not going to want that. All right? So it didn't work. All right, so now we're going to go back to our favorite question. What's his prognosis? So Dr. Chima, what's his prognosis? Would you really be enthusiastic about starting him on dialysis? No. No. Okay.
And I think his prognosis, we could go back to maybe one of the calculators and see if they help us, but I think maybe framing it as, I think we have data to say his prognosis is the same whether or not he does that.
Yeah. He may fall into that category of patients. In fact, I'm going to show you a recent study that was in the Annals of Internal Medicine that pretty much, sort of was interesting, additional observational study to sort of make us be aware that some of these older patients with comorbidities may not survive any longer with dialysis than without dialysis. Okay, so we've talked about that. And really, how should discussion with Mr. R and his son be approached? And really with a recommendation, based on what I know about your values and your preferences and your functional status, I wouldn't recommend dialysis for you, okay? I would recommend active medical care without dialysis, and we're going to talk about that a little bit more. But if we look at the United States Renal Data System 2023, this is what has been happening. And of course, the 2023 data is 2023 report is 2021 data. But as of 2021, of dialysis patients, 83% were starting on in-center hemodialysis, only 13% at home, and preemptive transplants. In other words, before they needed dialysis, only 3%. Now, that home dialysis number is creeping up because of the advancing American Kidney Health Initiative. I think it's up to 14 or 15%. It's not taking off like crazy, though, okay? But there are other options. So on the right-hand side of the slide, there's a time-limited trial of dialysis. If you're not sure it's going to really benefit them or not, you could try it for a couple of weeks or a month and reevaluate. You could do palliative dialysis because we really don't think he's going to live a year, but we could do it. And maybe palliative dialysis, at least in the nephrology literature, maybe only once a week or maybe for only 3 hours twice a week. The goal is to achieve a quality of life the way the patient defines it, not to get the world's best dialysis index, okay? So palliative dialysis has been described. There was an article in JASN a couple of years ago. Older patients are maybe not ready to make a decision, and they might decide not to decide and basically say, yes, I know I'll have to make a decision about this in the future. How about if we agree that in 4 months we'll talk about that, or whatever. And then there's active medical care without dialysis. So in this Kidney International article that I referred to earlier, they actually had a table on indicators to identify patients who might benefit from active medical care without dialysis. Poor quality of life involving irremediable suffering, such that dialysis may extend life and prolong suffering. And we talked about the patient yesterday with the fellows who had metastatic cancer to the bones and was in severe pain. And we might be keeping him alive to have his suffering actually get worse from his metastatic cancer. Frailty associated with cognitive and functional impairment. We don't know that he has cognitive impairment, maybe a little, but he does have significant functional impairment. If he had high comorbidities, severe malnutrition, a no response to the surprise question, would I be surprised if this patient died in the next year or in the next 6 months? And that's been validated with use with both nephrology nurse practitioners and with nephrologists, or those whose condition precludes the technical process of dialysis. You have a patient with advanced dementia who wants to pull out his needles, right? Dr. Isakova, you want a patient who's sitting on dialysis trying to pull out his needles? No. Blood flow rate of 400 milliliters per minute, and the blood just starts shooting everywhere. Fortunately, we now have blood pumps that shut off in that situation, but still that could be a real hazard. Unstable medically. I think Dr. Leidner and I talked about profound hypotension, right, and not being able to actually physically dialyze somebody, or other symptomatic life-limiting illness. So actually there are indicators that are identified that would make Dr. Chima and I reluctant to be enthusiastic about starting dialysis. So unfortunately, the nephrologist for this patient couldn't find a recent serum albumin, so I gave the benefit of the doubt and said it was 3.5. I doubt it was 3.5. We all agreed we wouldn't be surprised if he died in the next 6 months. He did not have dementia or peripheral arterial disease, so his 6-month survival was 76% with dialysis, but his 12-month was only 50-50. So again, it is a limited prognosis. And why might patients say that they would want to do active medical care? So what I want to point out to you is there are over 20 articles now in the literature. So this was a scoping review that just came out in April in Nephrology, Dialysis, and Transplantation, basically summarizing what have the reasons been that patients have given for not wanting to start dialysis. Not being tied down to a schedule, they're willing to trade off independence for a longer survival. Quality of life is more important, as many studies have found, more important than quantity of life to patients with kidney disease. In fact, there's let me see if it's the next slide. I don't think I have it. But there's a really nice, oops, I'm really going the wrong way. No, going the wrong, sorry. There's a really nice Australian study that shows actually symptoms were better controlled in patients with active medical care without dialysis than in another population who started dialysis. And their hospitalization days were fewer for the patients who didn't start dialysis. So all these different reasons. Saw somebody on dialysis, a family member, a friend, they don't want to go through the burden. Or some people say, I'm at the end of life, I don't want to go through the bother, okay? I just want to have a peaceful death. But our patients really like the fact that active medical care without dialysis is active. We're doing everything we can to prevent failure of their kidneys, to prevent progression of their kidney disease. We're controlling their blood pressure, treating their acid-base imbalance, treating their anemia, managing their bone mineral metabolism. We're controlling the volume status. So don't dismiss them from your clinic if they don't want to do dialysis. You've got lots that you can still do for them. And then you would add in the primary palliative care. If you feel comfortable, you're going to call Dr. Hauser, or Dr. Wood, or Dr. Vermillion, or I don't think, I met a fourth, I don't think he's here. Is he, Andrew?
No, he's not.
Okay. But you could call one of your palliative care specialists to help you with pain and symptom assessment and management and advanced care planning. So I wanted to show you this video because our patients helped us to make this video. So let's see if this works, okay? And this was something that they liked to get an unbiased.
If your kidneys fail, you have a choice to make. You might want a transplant. You could do dialysis at home or in a center. But some older people want to keep their lives the way they are now. Living longer may not be the same as feeling well. There is a third choice, conservative kidney care. Here we will call it active medical care without dialysis. It is given by a team of doctors and nurses. If you choose this, the goal is for you to feel as well as you can for as long as you can, and to keep you out of the hospital. It works. Those who choose active medical care have fewer hospital days than those who do dialysis. Why might you choose active medical care? If you are older and have other severe health problems, it can give you freedom from strict dialysis routines and side effects. It can give you time for yourself, for your family, for friends. Older people tend to live 14 months or so with active medical care. It could be longer, it could be shorter. With dialysis, they may live a few months to a few years more. If they are quite ill when they start, dialysis may add less time to their lives. With active medical care, you stay in close touch with your care team. They see you often to be sure you get the care you need. The aim is to help your kidneys last as long as they can. The care team will ease your symptoms, support your family, and work to improve your quality of life. They manage high blood pressure and swelling. They prescribe medicines to protect your bones and treat anemia. Reach out to your loved ones. Let them know the types of treatment you do and do not want, and talk to your care team. You can put your choices in writing in an advance directive. A medical order form can share your views about treatments like dialysis, CPR, or a breathing machine. Planning can give you peace of mind. It can help to know that your wishes will be respected. There is more help too, like palliative care. A doctor or nurse can treat your symptoms and help you feel better. And they can give you and your loved ones emotional support. At the end of life, hospice can offer more. So can a faith guide. Active medical care more often leads to a peaceful death at home than dialysis does.
So the patients helped us write the script, and they helped us with all of the animation images, and they were satisfied. I don't know what the reaction of this group is, but they felt it was balanced, and we do have an evidence base to support this. And so this is a patient decision aid that we're using. We're going to have a one-page handout, front and back, that reviews what the video says. Yes, Josh, Dr. Hauser, sorry.
So I was struck by the 14-month prognosis with active medical care. And the question that, and I'm an inpatient
Yes.
palliative care doctor.
Yes.
So the question is at what point in time is that prognosis?
Yes.
Right, because they're obviously not dialysis dependent at that point in time.
Right.
At least I don't think they are.
Right.
But I'm curious from, again, your perspective as
Yeah.
a nephrologist, other nephrologists in this room, sort of how we consider that number and
Sure.
pluses and minuses.
These are patients with an EGFR of 15 mLs a minute, okay? Looking forward, okay? And so, but that's good that you question that. So let me show you this other study from the Annals. I think it's my next slide. Yes, it is. Good. So this just was it appeared online August 20th. And this was a study in the Veterans Administration Health System, 20,000 patients, 65 and older, with an EGFR of less than 12, okay? And they followed them prospectively, and they looked at patients who then started dialysis and patients who continued what we would call active medical management without dialysis. And what you can see looking down here is that the days at home dialysis free actually was larger in those continuing medical management. The inpatient or nursing facility was slightly higher. But when you look at overall 3-year survival, it was very close. It was just a matter of days different. But what they said, older patients starting dialysis when their EGFR fell below 12, who were not referred for transplant, had modest gains in life expectancy and less time at home. So this, it's just another observational study. It's a fairly powerful one. I actually was a reviewer for this study, and I said to the Annals, I said, make sure you have a statistician who's familiar with this target trial emulation model. And it apparently, and then even on our research team, we had our statistician look at it, and it seems fairly solid. It's just another observational study, but it does add a little more evidence to the fact that, patients may not live all that much longer. Okay, so what's the main barrier? Because if you look at studies around the country, only about a third of nephrologists say they're comfortable doing active medical care without dialysis. Why do they say? Patients might change their mind and might crash into dialysis at the end of life. If they go to the emergency department team or the ICU might convince them to start dialysis. Family members might be uncomfortable with the decision and persuade the patient to start. Or maybe they couldn't get home palliative care services or hospice services soon enough, and therefore they didn't feel they had the support they had. And these concerns are legitimate because in a study that was, again, in AJKD, okay, it was experience of U.S. nephrologists in the delivery of conservative care to patients with advanced kidney disease. And the nephrologists described there was no infrastructure in place in their healthcare system. They had themselves to cobble together resources. It took a lot of their time. They had to help the patient navigate the system. And there was a powerful default in their system to just start people on dialysis, whether they were good candidates or not. And so they had to basically not only fight the system, but they had to fight their colleagues, some of whom were uncomfortable with not starting dialysis, okay? So what would kidney supportive care look like? What's it going to look like in the trial that we've got starting? It would be close follow-up by an APP or a nurse or a social worker, calling every week or two, especially as their eGFR drops. A care management call approximately monthly, symptom screening on every phone call and every visit, making sure we're providing care not only to the patient but to the family, advanced care planning, and then referral to palliative care and even hospice as appropriate and with the permission of the patient. Okay, so take-home points, and I was told I should leave some time for discussion. There are evidence-based tools to estimate prognosis for patients with kidney disease. I've shown you two. And an estimate of prognosis is integral to the process of shared decision-making. There's a recent consensus on the components of kidney supportive care and the role of nephrology clinicians in providing it. There are more resources than ever before to assist nephrology clinicians in providing primary palliative care. And for patients with kidney disease with more complex issues, nephrology clinicians should refer to specialist palliative care clinicians. And I was not paid by the palliative care physicians in the room to say that. I made the slides before I knew I was going to have palliative care physicians in the room. Okay, and just to show you, so resources for kidney supportive care, how to implement an active medical care without dialysis program, intensive support, how to do it, other things that are part of it. We have a toolkit that's available on this website for doing active medical care without dialysis. It even includes a letter. If a patient who's on active medical care without dialysis ends up in an emergency room, it includes a letter. Dear emergency department physician, I have chosen active medical care. It also includes a symptom management algorithm. Dear emergency department physician, these medications are helpful for these symptoms, okay? And then a symptom action plan that the patient knows, see, the physician, the kidney doctor, all this information. And then we have a list of resources, references, and then other items in the toolkit. All right, and so just to have you be aware that this is not a infant field now. This is a field that's developed, but I don't think it's widely known. So that's the reason why I'm so pleased that Dr. Isakova invited me to come talk about it. So questions, comments, reactions? Alex. Dr. Leiden. Yeah, I think like anything else, I would ask, what concerns do you have? And often family members or patients will bring up, what will my dying be like? And that would be a good time to address it. But of course, you have to open the door by asking, what concerns do you have? And those concerns may come up. Now, if there's good palliative care, it should be a peaceful death without a lot of symptoms, and the pain should be under control, the nausea should be under control. Can patients die horribly from kidney failure? Absolutely. Can they die in pulmonary edema? Sure. And so, that's the reason why getting palliative care involved or hospice involved earlier is a good idea. Would my palliative care colleagues agree? You can die horribly or you can die peacefully and comfortably, but it's a pretty good idea to get these colleagues in the mix, right? Does that sort of get other questions or comments? Yes.
So that was terrific. Thank you very much. I think what we struggle with right now, if we wanted to do something like this, is that we just don't have the manpower. and like you said, it's just a lot easier when to put someone on dialysis. I'm not saying that's what we do, but if we wanted to do this active management, you don't have the people to see them in clinic.
Right.
Yeah. We just don't have we don't even have the time slots.
You don't even have the time slots. So we are working with 11 nephrology practices that have 26 office locations in this Expand project. And we are training their nurse educators who may be advanced practice nurses or actually social workers or physician assistants. And we are telling them you can build an E&M code, and you can show them the videos. We actually have an entire slide set that can be done within an hour, and you can build a 99497 on top. So we have a mechanism to bill for it, and so it's a matter of hiring additional, but you may not have clinic space, so that's a problem. But hopefully, where there's a will, there's a way, build it and they will come, right? And so, and our coalition would be happy to help train nurse educators. In fact, we're doing that right now. I was talking to the palliative care team. I just watched some videos of our nurse educators that we've trained doing standardized patient video recorded interviews, and we're now giving them feedback. And it's delightful to me to see how the Ask approach is being used by them and is working. So the answer is we can help train them. You can bill for their time. It's a matter of obviously hiring them and then finding office space for them to see patients. But there are, what do we call them? We call them early adopters. And so we have these nephrology practices around the country that want to do it. Now the other carrot? The other carrot is that value-based care is making its head known among nephrology practices. And these nephrology practices, a lot of these nephrologists are very savvy about money. And they realize that an older patient starting dialysis who's frequently hospitalized under a shared risk value-based care model could cost them money in their bottom line. So they are all wanting, they're going to commit the money up front to hire the nurse practitioners, find the office space, because they feel these patients are going to save them money. And actually, Dialysis Clinics Incorporated has an upstream advanced CKD program where they've demonstrated the value, not just in terms of better quality care for patients, but actually cost savings from using this approach. So that's a long answer, but hopefully this will become scalable and more nephrology practices will do that. Yeah, maybe just one more question. Anybody? We're good? Okay. All right. Well, I'll stay here in case you have a question. Thanks.